Okay, good afternoon. Thank you guys so much for your time this afternoon. So I'm going to be talking about therapy approaches for our patients with substance use disorder. Next slide. Thank you so much in advance. So, as medical professionals, it's our job to provide the best patient care while also maintaining, professionalism and compassion. And so one of the ways we can do that is by facilitating appropriate psychosocial modalities and then using evidence-based approaches in those. So the following is a list of the, kind of the main psychosocial modalities that we use in the treatment of substance use disorder. So to start off, we've got individual therapy. This is really ideal for our patients that also have co-occurring disorders and/or a history of experience with trauma, which we know applies to most of our patients. We've got group therapy there. That's the main modality recommended for our patients. And for those of you currently running group therapy sessions, why. That support, the accountability that they receive from their peers is so incredibly influential, I think, especially early on in recovery. Also listed here that I won't talk a lot about today is family therapy and couples therapy. So we know the addiction doesn't just involve the individual, really it involves the, all of the loved ones in their lives. And so if we have the opportunity to bring their family members in, we can potentially affect change for the patient on a much wider level. Next slide, please. Thank you so much. So for those of us in the therapy field, we see firsthand the importance of the work that we do and the effect it has on our patients' long-term recovery. For other medical diseases or disorders, sometimes the treatment may just need to be medication alone. But for our patients with substance use disorder, we know adding therapy to the treatment helps in so many ways. So, for example, it helps them address the underlying trauma that's occurred for so many of them, as well as other co-occurring disorders that aren't going to be addressed just by the medication alone. It helps the patient learn about and develop coping skills, which they can do both in an individual or group therapy setting. As I mentioned before, that support, the validation, the accountability they receive from their peers is immensely helpful. And in all of those modalities discussed, we have the opportunity to provide education about addiction and recovery all along the way. Next slide, please. Thank you so much. So let's talk about some of the kind of main evidence-based treatment, therapeutic treatments that we use for patients with substance use disorder. There's cognitive behavioral therapy. CBT is present-focused, teaches skills that are valuable in assisting people in gaining that initial abstinence from drugs or maybe reduce their drug use. There's dialectical behavior therapy that can help treat severe and chronic substance use disorder patients. Again, those that have co-occurring disorders, especially those who struggle with suicidal ideation or self-harm. There's motivational interviewing or motivational enhancement that helps people with substance use disorders to build motivation and then commit to the specific plans they want to make for themselves in recovery. And then general 12-step facilitation therapy. Next slide, please. Thank you so much. Additional strategies include just general relapse prevention that I think can happen at all the other levels that we've talked about, yoga and mindfulness-based practices, and then contingency management or incentives. And then I just have a couple of other areas highlighted with interest. In the interest of time, just for today, I'm going to talk about just a few of these specific modalities in more detail with these follow-up slides. Next slide, thank you. So what is cognitive behavioral therapy and how can it help our patients with addiction? So CBT is a psychosocial style of therapy that focuses on challenging and then changing unhelpful cognitive distortions and behaviors. Helps improve emotional regulation and the development of personal coping strategies. The hope is that with CBT we can help teach our patients to find a connection between their thoughts, feelings, and actions, and then we can help them increase their awareness of how this affects their recovery. And this is a modality that has the greatest evidence basis for the treatment of substance use disorder. Of course, I'm going to start losing my voice. Next slide, please. So the ABCs of CBT are, there's an activating event that takes place that will trigger our current belief system or maybe just the current state of mind that we're in that moment, and that'll lead us to a particular emotion or feeling state. I'll use a totally hypothetical situation. Let's say I come home and I manage to find that my husband has put his laundry right next to the laundry hamper, but not actually in the laundry hamper. It's never happens, just hypothetical. If I'm not in a good headspace, if I'm not paying attention to my thought process that day or my belief system, I could experience that, and that's going to activate me to go, well, that lazy, good for nothing, how dare he, doesn't he know how busy I was today? He just expects me to do everything for him. And so that's going to lead me to feel, right, probably angry and resentful. Versus if I'm in a headspace, if I'm in a sort of more controlled, more rational headspace, I'm going to see that and go, you know what? He's been really good about the laundry. So if he did that, he must be really busy and distracted. I wonder what's going on with him today. And if laundry is the worst thing I have to complain about, I'm probably pretty lucky. Again, totally hypothetical. That's never happened in my household. Next slide, please. So I particularly love CBT, using CBT with our patients, because I find it very collaborative. It's a way to help build trust with them. It's not about me telling them what to think or what to feel, but engaging them in that process. It's very active for some of our patients who are maybe on the quiet side in therapy. This is something that there's sort of activities that takes a lot of, there's sort of specific work that we can use with them in sessions. So it's a little bit more active, it's structured and focused. The hope is that we're focusing on sort of present moment, what's going on with them currently. And again, it can be used in group or individual therapy. Next slide, please. Oh yes, and so again, within the COPE model, we can utilize CBT both in the individual and group setting, and it's a way to help them, recognize, so identify which triggers often lead them to use in the past, help them learn how to avoid those triggering situations, and then help them cope, so address and reframe the thoughts that lead to emotions that lead them to use. Next slide, please. Thank you so much. So dialectical behavioral therapy, this provides clients with new skills to manage painful emotions and decrease conflict in their relationships. DBT specifically focuses on providing therapeutic skills in 4 key areas. So mindfulness focuses really on improving an individual's ability to accept and be present in the current moment. Distress tolerance is geared towards increasing a person's tolerance of negative emotion rather than trying to escape from it. Emotion regulation covers strategies to manage and change intense emotions that are causing problems in a person's life. And then interpersonal effectiveness consists of techniques that allows a person to communicate with others in a way that's assertive. So it can help them teach kind of how to maintain self-respect and then strengthen their relationships. And then specifically with our substance use disorder population, we can help them, we're sort of helping contribute to community reinforcement of abstinent behaviors, helping them build bridges to new stimuli to condition abstinence. So it's another, I think I only have 1 slide about DBT, but it's another great option for our folks. Next slide, please. I'm going to take a drink of water. So motivational interviewing is a counseling approach designed to help individuals resolve ambivalence about their alcohol or drug use and support efforts to change it. MI is often delivered as sort of a brief intervention based on client-centered principles. One of the core stances of motivational interviewing clinician is that they're not there to argue in favor of change or really attempt to convince the patient that change is in his or her best interest. They're really there to elicit the patient's own argument for change. And then motivational enhancement therapy is an intervention based on the MI approach and practices. So again, the therapist really has a supportive, non-judgmental stance that they're taking with the patient. It's really meant about creating this collaboration with the patient to help them decide what they think is best for them. And it's a way to help kind of reduce the resistance that so many of us are familiar with, particularly working with folks really early in recovery. Next slide, please. So important sort of skill sets when folks are using MI. Again, it really emphasizes the use of common counseling skills, such as reflective listening, summarizing, paraphrasing. Advice is typically only given out on request and with the patient permission. So again, we're not there to tell them what to do. We're there to honor where they're at and get a sense from them, why are they showing up in your office? There's something about them that probably wants some change. So how can we help them answer, why they decided to come in to begin with. MI is also sometimes combined with other types of interventions, for example, CBT, in order to enhance treatment retention and engagement. Anytime I give a presentation, I always try to get some farm pictures in there. So this is me trying to use motivational interviewing to convince my goat to stop chewing on my shirt. Notice I'm smiling. I'm not judging her for doing it. I'm just hoping I can coax her away from stopping. She did not stop, by the way. Next slide, please. Contingency management. So this is a technique employing the systematic delivery of positive reinforcement for desired behaviors. This is commonly, this is sort of the main recommended modality in the treatment of methamphetamine use disorder. That kind of program, the way it would look would be that maybe vouchers or prizes can be earned for submission of methamphetamine-free urine samples. What's important about this is that it has to be simple. We want to make easy to track target behaviors, and then make sure there's sort of a little burden on the counselor or administrative staff. It can't be a setup where in order to reward the patients, you're having to sort of punish the staff in the process. This one sometimes can have more staff resistance that we want to sort of talk about. Sometimes folks will have the impression that they feel like patients shouldn't have to be paid or bribed to treatment. They should, sometimes we think, well, the recovery should be the reward. That's why our patients are showing up. Or we want their motivation to come from within. And so we want to reframe contingency management, help to see that it's a way to engage them and to retain them early in treatment, along with the other interventions that we're using. Next slide, please. Thank you so much. So the basic principles of contingency management or incentives are, again, frequent monitor target behavior, provide incentive when target behavior occurs, like the strawberry, I'm giving my little pick, or remote incentive when target behavior does not occur, and then repeat that habit over and over, or that cycle over and over. Next slide, please. And then overall relapse prevention, so when we talk about relapse prevention, again, we can use that with the other modalities that we've talked about, or just in general. We want to incorporate CBT strategies. We want to emphasize help our patients to emphasize developing that awareness of what those warning signs are, helping them recognize what are the changes in behavior, attitudes, emotions that maybe lead to a relapse, help them identify those triggers, people, places, and things. Also help them establish a strong social support network, so friends, family, members in the community, other members in the recovery network. There's several core components of a solid relapse prevention plan. What always helps to start with your patient is to help them and their family have a realistic expectation. I always say, if I have a patient who comes to my office and says, well, I'm never going to drink again, I sort of want to point out to them that could potentially be a danger sign, because we don't want to minimize the hard work that's ahead. And so it's really all about one day at a time. Next slide, please. And as we know very well, the substance use disorder population comes with a list of unique treatment concerns, and this can prevent them from participating in psychotherapy in a way that we want them to, and in a way that's potentially going to be effective based on where they're at with recovery. So we know this is a group that has higher rates of domestic violence, and that could prevent them from coming to appointments. I don't know if you all have had this issue, but with telemedicine right now, I've sometimes had the issue of patients need a session. They can't come in person, so we have it over tele, but they live in a house where they're not able to talk about certain things in their relationship because their partner's in the other room, and they don't, live in big houses where they can have their own space. So, domestic violence keeps them from treatment. Higher levels of shame and guilt. There's a possibility that when you're meeting with a patient, you may be the first one they've met with in the healthcare system who has not shamed them in some way or treated them a certain way. So they are going to be coming to you with their own level of shame and guilt and their own sort of experience with folks in the field. Fear of CPS intervention, so that's key. If I am a patient and CPS is involved, and I know I need to be honest with my treatment team because that's the best way to get the most help, but I'm afraid they're going to report something back to my CPS worker, and is that going to prevent me from getting my kids back sooner? That could potentially get in the way of treatment. Same thing sort of in general, just fear of legal involvement. Childcare issues and transportation issues. Childcare issues has been a huge battle these last several months, right? With our patients that have their kids home because of COVID, they're either able to not come in person to a session or we're on a telesession, but I know I don't really have their whole focus because they're, worried about their kids in the next room. Transportation issues in West Virginia is common. Tele has, I think, helped that a little bit, but in general, that will be an issue in our rural area. Employment issues and financial limitations, that's come a lot. It's come up a lot during tele. Either folks have lost their jobs, and that's what was helping them contribute to paying for their treatment, or their sort of job schedule is all over the place because of COVID. At risk for general medical complications. I have a lot of patients who are just dealing with so many other physical health issues that they're not able to come to all of the individual therapy sessions that they really need for us to kind of tackle together what's going on. And then a general lack of support. For some of our patients, they're lucky they've got family, friends behind them, supporting them and being here. And for some of our patients, they may be the healthiest in the family. The fact that they're here getting help is a good sign, and they may not have that support that they really need at home. Next slide. And just always a good reminder to treat this population with as much empathy as possible. And that's my presentation.
Thank you so much, Katie. That was awesome. I always love your farm animal pictures. That always
sometimes they don't make it all any sense with the slide that they're on there, but I'm still gonna put them in.
Hey, you made it work. I love it. Are there any comments, questions, thoughts from the group for Katie?
I just wanted to say that it was really good, and never ever stop using your farm animals.
Thank you, Andrew.
Disappointed.
Thank you, Andrew. I will keep that in mind just for you.
I had a question. Katie, how do you all go about getting funding for contingency management?
Oh, that's a great question. We literally just talked about that today, that we're trying to figure out how, so really that's a two-parter, right? So we need funding to train our staff, and that includes all of our staff with the contingency management training, because if we're using that with our patients, it's not just going to be the therapist that would be part of it. It would be the whole multidisciplinary team. So we are just in the process of figuring out how can we bring money in for that training, and then, realistically, how much money would it take to kind of have a self-sustaining contingency management program for, a year or so. So I don't have an answer to your question, but Sheena and I are trying to figure that out right now.
Yeah, because what I was thinking of doing over here, some of the research we're doing is based on methamphetamine. So I was thinking, man, if I can make a good argument for that inpatient and then kind of present it to CMC Foundation, say, hey, this inpatient, it's outpatient, and look at our co-program. We have this issue. Would you all be willing to do some funding? But that'll be like paper and grant right in, and that'll take a year. That was too sure if that's going to be like a faster way. Sure.
I will check with Sheena to see if there's a faster way to figure that out.
I doubt it though. Yeah, the only time I've ever done contingency is at VA, and they had a lot of funding for that, and it was so helpful.
Yeah, absolutely. Good question, Dr. Boyle.
I just wanted to suggest differentiating with empathy, empathic concern versus empathic distress. So sometimes people are so empathic that they wear the kind of the negative emotion of someone's suffering. And I think you want to be concerned, but not identify with the patient.
Oh, great. What was it? Empathic distress and?
Empathic concern.
Thank you, Dr. Hirschler.
Well, if no one else is going to go, I want to ask Katie another question. Okay.
Yeah.
So dumb me, Katie, right? I tried to do family therapy.
Dr. Bow, I'm so sorry. There's a fire alarm going on, so I'm just going to mute myself on your.
Oh, okay. Okay. So I was trying to do family therapy with someone, but it was alcohol use disorder. So we'd come in, I'd have him set his goals with his mom, and figure out, well, what's the goal of this? What do you want in terms of relapse prevention and abstinence and so forth? And you know what? I had the hardest time keeping them on track. So they were the most compliant people, and they would come and meet with me every week, right? And so they were getting something from it. I wasn't too sure what, because every time we'd set a goal, a set of homework, it was never followed through. Like, for example, one of the things we said was, well, his mom said, well, you know what, if you were drinking, if I was sure you were drinking less, it would cost me to trust you more. Maybe it'd have more, it would help our relationship. So then the decision was, well, how about use a breathalyzer at home on a daily basis, just blow into it, write it down. That way you have more accountability. Never done. So just things like that. And I was wondering, like, how do you even, like, what would you do in a situation like that where the family, they want to meet, but the goals of treatment are not being met? And in fact, what happened to this gentleman, he kept hiding his use over and over. He ended up in the hospital with fulminant liver failure at 40 years old now on a transplant list, right? And so so he's out of the hospital now, and they're like, Dr. Bo, we want to reestablish with you. And I go, well, I don't like to repeat the same thing if it's not working. I like different approaches. And with this gentleman, I tried MI, I tried CBT, I tried relapse prevention, I tried everything. So what I'm suggesting to them to do is to reestablish with our new therapist, who will definitely have a different approach. But it was, you know, Katie, it was really frustrating. I kept thinking, like, what am I doing wrong? Why can't I get, I can't get them to focus on the goals they said they wanted to do and actually follow through. Any feedback?
Yeah, Dr. Bove, that's a great question. Before I answer that, anybody out in ECHO, you know, have an experience with that? How would you have handled that situation for Dr. Bo? Okay. Dr. Bo, if that, so first of all, thank you. That's just sort of a good kind of case presentation. Thanks for sharing that. If it were just the patient, do you think you would have felt that same level of frustration? You know, have you ever had a patient?
I mean, actually, yeah, when his mom came along, it got better. Okay. What, you know, I think you did I like your approach of, you know, look, I tried sort of these modalities, and if these modalities in my style didn't work, what would happen if we tried a new provider? Because sometimes a new provider is a new perspective, and sometimes it's also, it ends up being a sort of unconscious shift in the family or in the patient's perception of, maybe this is a fresh start. Maybe we're going to come at this from different, not that that next provider is going to work any harder than you, but sometimes it can reset things for the patient and the patient's family. Does that make sense? Oh yeah, good. Because I was feeling guilty, because I'm like, they really, really want to meet. And I'm like, for what? I mean, usually I do therapy sessions for 12 to 16 weeks and stop and reevaluate. Yeah. I met him for a year, Katie, and nada. Yeah. So, and
Dr. Bro, isn't that the population that we work with, though? I've seen some patients come through COAT, right, over and over and over, and it's not the first or second or 20th time. Sometimes it's the 21st time where it starts to click and folks go, okay, all those things you were telling me all along, they're starting to make sense. They're starting to sink in. So I also have no doubt, if they kept showing up, you were doing something for them. You were doing good work for them. And if they were willing to try to start with a new provider, that's because you were planting seeds to make that happen.
And boy, you know what, they make people feel better.
That's good. That's what they pay me here for, so that's good. Great question. The fire alarm has stopped, by the way.
Thank you, Dr. Bo. Anyone else have any stories or similar situations they'd like to share? Or an informal case anyone would like to share? We still have about half an hour, so.
It was good to hear you talk about that, Dr. Bo, because it sounds, you know, familiar, and it is interesting when people keep coming back in spite of not seeming to make any progress. And there have been a couple patients in our program that we've really tried to measure just the smallest increment of progress, which I guess wasn't even possible with your guy, and I'm not even talking about family therapy. But the other thing that it reminds me of is just my care of other chronic disease patients. And I've been thinking a lot today for other reasons about people I've taken care of with diabetes for years who I haven't been able to affect much change with, who are now having complications from their diabetes. And I'd kind of like to be able to offer them somebody else to see because I feel ineffective. So I hear your pain. That's what I'm saying.
I feel like, so first of all, thank you so much for sharing that. I would love to hear from the other folks on the call. What do you do when you're feeling ineffective? If you've got a patient or a family that you're working with and you're, feeling like you're coming up against a wall, how do you take care of yourself as a provider during that time? Because that's a great opportunity for burnout, right?
I do Dr. Morrison's approach. He said the other day.
I didn't hear us the other day.
You smile and you just encourage.
I'm sad he's not on the call to hear that from.
I'm sorry, that's horrible, but he cracked me. That was a few weeks ago.
Oh.
He cracked me up on it.
I can hear him saying that.
I forgot that he said didn't he say he kind of fakes it?
Yes. Whenever he doesn't know what else to do.
I forgot about that. I could be really good at that. I need to employ that.
No, that's when I didn't forget because I was cracking up and I wasn't.
He will be honored to know that he was talked about on this call, even though he's not here. Who else? What else? What do you do? How do you take care of you?
I think talking about having our own group therapy, like legitimately.
Yeah.
Heather, Desta, me, or whoever, getting together and talking about the cases and having some of that downtime to process. And as we're talking about it, maybe I have gotten a little too involved, or Heather or whatnot. And so that time's really important, I think, to reevaluate and to assess and kind of regroup.
Absolutely, totally agree. Same thing with our treatment team here. If I'm sort of feeling stuck with somebody, chances are I'm working on a team with somebody who isn't in that same stuck space, so they can help me, and then vice versa with another patient. So I love that.
So what have people's experiences been using kind of app technology, especially recently when in-person groups have been limited a whole lot more in terms of, your personal experiences with effectiveness? And what we're working on right now is with a brand new MAP program. And so they're trying to find ways to navigate starting a MAP program during COVID and things. It's also a very rural population. And so ways that they can still stay in touch with patients, given a lot of the restrictions that we have right now, or even sometimes the transportation issues that they're dealing with to get to therapy appointments.
Yeah, great question for the group. Anybody want to speak to that? What's your experience with, and am I saying it right, Brianna?
You just call me Bree. That's easier.
Okay. And so it's just what's people's experience has been with kind of teleservices so far? Is that what I hear you asking?
Yeah, it could be telehealth appointments in general, or some of the specific apps that have been developed and supported by some of the payers in the state. The Chess app is one that comes to mind for me that I know that the state has put some support behind.
Yeah.
Okay, so what we have been using is WVU platform Zoom. And Cheryl, our coordinator, is awesome. I mean, because if I was in charge of that, that would be a mess. So for us, it's been, it took some work implementing, but it's pretty smooth now. And actually, I really, really like it. Because I think when we talk to our patients, we're able to be more engaged, because now I can specifically ask, hey, you didn't I noticed you didn't say anything, you know, kind of draw you in. Also, it's easier to play games. I like to play games. So it's easier to get that going, I think, on Zoom as opposed to in a big room where some people are more engaged and others are not. So I've had pros and cons, and definitely the attendance rate has gone up, that's for sure, because people can just check in wherever they're at. We have had issues more so with the privacy in terms of other people being in the environment, but when you just kind of remind your clients that, hey, you know, make sure you're in a private place, it's been okay. We have had issues with technology in terms of it cutting in and cutting out, but we kind of just work with it. But Cheryl's awesome though.
I had great hopes for the video stuff, but I think you're right, Dr. Bo, on all of those things, you know, in terms of accessibility and all that. But the cutting in and cutting out is so much, and the connection problems we have, it's very disruptive and it's very hard. We've actually been using our outside picnic pavilion for a group. They said, we can't do this anymore. They were so disconnected, and it's very hard to keep people. It's a lot of more work than in person, the group. So I think it would be better if our patients in our state had better connectivity, but it really has. At the beginning, we're like, okay, we can do this, we're going to survive. But as this becomes a long-term plan, this isn't anymore, oh, we're doing this for 2 to 3 months. We're doing this for the next year, probably, because of groups, you know what I mean? And so I think that's what we're facing. We're, you know, we're trying to reduce. And so I think the connectivity issues are really a problem for us. Patients cutting out, you know, and it's the same people, it's where they are, it's all this stuff. And so it does take a lot more work to kind of connect with people. The groups are shorter. They're not bad, but they're not as productive as they used to be, I think, now that we've gotten through it. And then patients are actually wanting to connect with each other, which is, you know, really good. That's their community, but I think I wish it were better.
Mm-hmm. I think there was did somebody give an echo presentation? Did Laura Lander and Emily Choco give a presentation maybe 2 months ago about kind of
Yeah, like best practices.
Yeah, okay. I can also ask, so Emily Choco is like our sort of guru in terms of group engagement. It's like that's Emily. So Emily Choco's our therapist. She's been with us, I don't know, a handful of years now. Emily loves the challenge. And so she had actually started to do telegroup several years ago through a grant project. So she was already very comfortable with this when we had to throw everything on tele last spring. And so she loves the challenge of like, how do you figure out, you know, if you've got half the people in your Zoom group engaged and really paying attention, and half of them are, you know, sort of paying, you know, not paying attention, doing something else. She loves the challenge of how do you engage them and how do you keep the group focused when 3 people's internet keeps going in and out. So she could be somebody I ask, even though she's not really generally a part of ECHO. She may be willing to come in and kind of give a quick presentation on that, you know.
Yeah, Katie, we were actually sort of talking with her to maybe do a mock teletherapy session instead of like a case for one of the sessions. So I'll reach back out to her and see we can maybe coordinate a day and time for that. So that'll be a great idea.
I learn something from her every time I am a part of, you know, one of her presentations or educational components.
Yeah, and I'll also go back to the YouTube page for ECHO and take a look for the best practices one too. I think that'll be helpful for us.
Bree, those sessions were helpful for me, and my situation was that I started prescribing in the MAT program 3 weeks before everything shut down for COVID, and so I didn't. So it was a super steep learning curve for me because I didn't have relationships with the patients. I didn't have familiarity with the COAT program, and then we moved to virtual, and so I found and interestingly, we initially it was only recently at the encouragement of the group here and those ECHO sessions where they talked about how to do group sessions that we moved into group sessions. And so I was doing as individual calls, video chats or telephone calls with people, which in some ways was easier for me in the beginning to establish a relationship with those patients and kind of understand where they were coming from and not have to figure out how to do a group visit and then how to do a group telehealth visit. But now we've moved into group telehealth, which it still just feels pretty awkward, but I think it is going to be necessary for a long time. And as of the past 2 weeks, we've brought people back in very small groups in person because they really, I mean, it's clear that it's just so beneficial for them to be together. And it just feels better to me too.
Yeah.
It's a relationship building thing, I think. And then all the benefits, even that Katie talked about today, of being together in a group. There's probably a way that I could learn to do the group telehealth in which it could be more interactive, but it's such a, there's a lot to learn.
And for me, it's hard to, some of my patients are going to really be able to honor this group space on tele and sort of create it like a ritual, you know, and there's a particular place in their house they go to when they, you know, sign on for group, and they can find a way to kind of recreate that, you know, walking in for group therapy session the way they sign in for Zoom. And for some of our patients, based on their resources or lack thereof, they're not going to be able to do that. So I keep telling myself it's a wonderful alternative. I'm so glad that we have this during this time, but I very much look forward to having my peoples back in person.
Has anyone else experienced challenges with teletherapy or anything telehealth related, and maybe ways that you've worked around it? Feel free to use the chat feature as well.
This is Mark Fuller. I just wanted to share a little different experience we had that we didn't expect. So our no-show rate runs around 25%, between 23 and 25%, which we attribute to stigma, reluctance to engage in treatment, denial, things like that. So in COVID, when we switched to almost pure telehealth, our no-show rate dropped to 7%. And it turned out it wasn't stigma, it wasn't denial, it was childcare and access to transportation. So all this time, it turns out telehealth helps with that those main barriers, which were getting here and find a way to watch the kids and have responsibilities taken care of. So that was a very pleasant and unexpected surprise for us.
Absolutely. I know here for W Medicine, I know our no-show rate with the COPE program has decreased. I don't know if it's as huge a number. What did you say, from 20 to 7?
25%.
25 to
7%.
That's awesome.
It turns out people really do want to talk to us. They just don't want to take 2 buses across town, sit in our waiting room for half an hour.
Sure. Sure. Oh, that's great. Thanks for sharing that.
Absolutely.
Any other questions, comments, or thoughts that you'd like to share with the group?